If your child has been diagnosed with ADHD, you might be considering your treatment options. The American Academy of Pediatrics recommends that for children between the ages of 4 and 6, the first line of treatment should include parent training and behavior management and behavioral classroom interventions. Medication should be used if those interventions don't provide significant improvement or if the child continues to have serious problems. For children and adolescents between the ages of 6 and 18, recommended treatment is FDA-approved medications along with parent training and behavior management and classroom interventions. Treatments often work best when used together. Because parents often have so many questions about medication, I wanted to be sure to have those questions answered by a pediatric psychiatrist. My guest today is Dr. Syed Naqvi. He is a board-certified and recertified child and adolescent psychiatrist. He provides state-of-the-art psychopharmacological treatment to children with autism, intellectual disabilities, psychiatric issues, autism spectrum disorder, bipolar disorder, ADHD, and Tourette's disorder. Dr. Naqvi has been the recipient of numerous awards. He's a clinical associate professor of psychiatry at UCLA, and he devotes his professional time as director of psychiatric services at Wayfinder Family Services in Los Angeles and in his private practice in Beverly Hills and Calabasas in California. I am so thrilled to have him here with me today.
Millions of kids struggle with learning, processing, and social emotional difficulties. These challenges interfere with their ability to reach their full potential. Dr. Karen Wilson is here to help. Her extensive background in pediatric neuropsychology and higher education have prepared her for this unique mission. Listen as she delivers content to inform, educate, and empower parents and educators. This will enable you to identify challenges that kids face and get them on the road to achieving their full potential. This is Diverse Thinking, Different Learning by Child Nexus.
Dr. Naqvi, thank you so much for joining me on the podcast.
Thank you so much for having me. It's such a pleasure and a privilege to be a part of this, such an auspicious endeavor, really. And I'm so delighted that I'm here and see if I can be of any possible help and assistance.
Well, I know that you can. And I actually wanted to do this podcast because of years of having conversations with parents who want to better understand how medication helps kids, particularly those with ADHD. And so, before we even jump into the conversation about medication, first you have to decide as a psychiatrist whether medication is even appropriate. And when I make a diagnosis of ADHD, I'm referring them to you or another psychiatrist for a medication consultation. And I tell the parents, I don't know if it's going to be appropriate, but I send them to you so that you can make the decision on when it is appropriate. What is your thought process when you get a referral like that from me?
I'm more like a purist, I'll be honest with you. ADHD is a clinical diagnosis, though I will talk about biology in a little bit. And for me, an attention deficit hyperactivity disorder, predominantly inattentive type, predominantly hyperactive type, or combined type, has to justify the time-honored statement in 2 or more settings, not norm for age, causing gross disturbance. One of the faux pas of the field has been that sometimes you only lean on the parental feedback. As you know, Karen, you do it very well, input from the school where the child spends 9 to 5 or 7 to 8 hours is quite pivotal. So in 2 or more settings, not norm for age, but has to cause gross disturbance. Now that becomes a clinical judgment in some shape and form. What I'm saying in simple English is that I do not think it is okay to say that every ADHD needs to be treated by medication. You have to balance it in those pros and cons. The second point is the pros and cons need not be only short term. As people working with children, we think not only about today, we think about tomorrow and day after tomorrow, i.e., what are the long-term risk-benefit ratio with the use of biological interventions. But let it be said that, attention deficit hyperactivity disorder is a neurobehavioral disorder with abnormalities in various neurotransmitter systems. We know that. noradrenergic, serotonergic, dopaminergic, and there are various degrees of attention dysfunction, impulsivity, and hyperactivity that interfere with the day-to-day functioning. It's the day-to-day functioning, both at school and at home, which needs to be deciphered in depth before you can say that medication can be a part of the larger treatment plan.
Absolutely. And I love that you say a part of the treatment plan, because it's not the sole intervention for ADHD.
No.
And, for parents who are listening or for individuals who are listening, we don't make that diagnosis lightly, that we have criteria we have to follow. And like Dr. Naqvi saying, these difficulties have to occur in at least two settings. It's usually home and school, and it has to interfere with their functioning, which is what we use as a guide to making the diagnosis.
Yes, almost certainly true from that premises. And the second part is that there is child psychiatrists, child psychologists think like parents. What is the least offensive way of turning the tide, of making a difference? I think one has to be very cautious and conscientious not to jump to the best possible, the most potent solution. I often see that. Why don't you give the magical potion which can turn the tide? Yeah, but then you do not want to make the cure worsen the disease itself as well. So, I'm not trying to be philosophical, but I think when it depends on the age of the child, it level depends on the disturbance of the child, et cetera, et cetera. ADHD seldom comes alone, as you know. That's the second point. Many times we get so much focused on ADHD, we forget that more than 50% of kids may have disruptive behavior disorder along with ADHD. Oppositional defiance conduct comes to mind. About 35%, 37.5% in some studies may have anxiety disorder along with ADHD. Tic disorders along with. So the point I'm making is that once you have seen the baseline of fulcrum of the base as ADHD, one should really spend exhaustive time, focusing on where the child is in the chronological age to see whether there's a comorbidity. Because sometimes when you treat ADHD without defining those comorbidities, you can actually make the cure worsen disease. If somebody has got anxiety and ADHD, here you're using the time-honored stimulants which we use in the field, and you make the anxiety worse. The outcome is not going to be good. So I think that sensitivity is also important. I mean, that's the key point. That whenever the fellows in my teaching hospital would come to me, I always say, okay, you've got the diagnosis of ADHD. What else have you missed? Is there any learning disability you have missed? Are you sitting on dyslexia which you have not focused on? So that ethos has to percolate when you look at the parent.
And it absolutely does. And that's one of the reasons why when parents call and say, I want an ADHD assessment, it's almost impossible to just do an assessment for ADHD, because 50% of the time, like you said, you're going to be missing something. Because if you just test for ADHD and you get, a positive diagnosis, you still haven't evaluated whether or not there's something else that's coexisting with it.
Yeah, wonderful.
And so, when we think about we've made the diagnosis, we're sure that it's ADHD, and we can't just stop there. It seems like we know that there's a biological factors that underlie the presentation of ADHD, but you have to also look at learning environment of the child. You have to look at the family systems. How do you take those into consideration when deciding on a course of treatment?
I think one thing which I think, Karen, you do so well, every child does not or cannot go through thorough neuropsychological evaluation. In the clinical assessment, I'm quite hawkish about using standardized scales. If the mom is saying these are the symptoms of hyperactivity, impulsivity, poor impulse control, etc., I want corroboration. So I tend to use the Vanderbilt scale, as you may not know. Connors is another. Without getting technicalities, I'm not promoting any of these scales, but I want to use validated scales, very objective, that somebody can define for me as to what is the issue which is being. Simply saying he's a disturbed kid, he cannot be handled, is not good enough. So that's what I use quite diligently, and try to use it diligently in the follow-up and care, the interventions which I'm doing biologically, psychosocially, educationally, all that milieu stuff. Then it is producing objective improvement in the child or not. So that's the second thing which I use a lot in that frame of reference. And third, which I think is important, is that there are times in a complex child with ADHD, if I can see the beginning of a learning disability, reading disorder. I mean, one doesn't have to be a rocket scientist. I had a child in my practice doing very well in math, doing very well in science, doing extremely well in history and social studies, and then you see the scores in English and language arts. They were at rock bottom. Well, it did not bring me any pleasure. I was suspecting, cut the long story short, at 10 years of age, in thorough assessment, it turned out, yes, she had ADHD, but she also had a reading disorder, which had been deciphered. Point is that you cannot keep pouring in medication in that child without getting to the base of that. So these are some of the things I use in my approach and see, what's the best outcome at that age. Now, for a 9-10-year-old girl, I would not like to be extremely hawkish. Algebra is not there, calculus is not there, algebra 2 is not there. I can go on and on and on. Pertaining to that milieu where she is functioning, making sure the educational environment is okay, I may come with medication interventions. They might be on the softer side. Till such time she becomes a high school student, where the onus of the gravitas of the work requires that she gets an additional support. So I think one intervention is not the same for a 9-year-old versus 13-year-old versus 14-year-old versus 18-year-old. I mean, that's a very important point. That's why educational therapy comes in. Learning how to learn comes in. Small structured school size comes in. I mean, all the things which we can talk about without belaboring the point. That's a very comprehensive approach at the stage where the child is in, and then taking it step by step forward, and match the intervention, match the support. Again, not only biological, psychological, social, educational as well, embracing the journey in that sort of a comprehensive 360 way, if I could, 360 degrees way.
And I think that is the standard for diagnosis and for intervention for ADHD, is that there's not a one size fits all. Like you're saying, you have to consider the age of the child. You have to consider their learning environment. If they're in a class with 40 kids, it's going to be very different than a small, private school that has 10 children in the classroom in terms of managing the ADHD symptomatology.
Absolutely. More one-to-one sitting in the front row where the teacher's attention is there may obviate at that stage, at 9 years of age, just focusing on that example which I just gave, sort of pouring in a medication and trying to hyper-focus the child itself. So I think that kind of a comprehensive, broad-based approach is, and then I think the last point is reevaluation. I always am asking myself, okay, fine, I've done the intervention, child is doing better in the school, what else am I missing? Keeping pace, always reevaluating your intervention every 6 months to a year, and then tailoring it accordingly. A primary school may be okay in a certain milieu with the 40 kids, with some interventions, make her or him sit in the front of the classroom, but may not be okay in middle school, and may become totally unacceptable in a high school where so much multitasking, executive function comes into play that you have to do So I think people ask for a 2 + 2 making always 4 kind of solution, and they leave my office and look, at this moment, this is what we're going to do, reevaluate our successes, reevaluate what we need to do. And I think the last point I want to make, Karen, which you are much better than many of myself, I would say, we in our psychiatric work, I must say, oftentimes have not focused enough in ADHD and in the child in mathematical disorder, in reading disorder, and in writing disorders. I mean, the learning disability part somehow does not occupy that primary focus in our radars, which has to be there. Because you're not going to correct a mathematical disorder by pouring in more medication, by making the child sit in the front of the classroom only. You have to find out what that actually is. If somebody is nailing all the subjects and is plummeting in math, then the red light should go on in your mind and say, hey, why is that so? Like in this child I was mentioning, grades were absolutely fine, and in reading and English language arts were quite bad. And when you deciphered it, it found out that reading was an issue in that, that kind of. So that approach, I think, is extremely important as well.
Absolutely. And it's why, I really lean into doing a more comprehensive evaluation, particularly when parents and educators don't know what's causing the problem. Because you can think of it's ADHD, but if it's ADHD plus something else, you're going to be missing it. And like you said so eloquently, treating ADHD that is really comorbid with dyslexia is not going to address the dyslexia.
No wonder. And I think you cannot miss the forest for the trees. And you understand it's human nature, the squeaky wheel gets the grease. If the child has got behavioral issues at the playing field, that will come front in you. You have to go to the root cause analysis and then try to really, and that's why I think children and adolescents are so much challenging, because it's a constantly shifting paradigm. It's changing. Their mind is changing, their life experiences are changing, their hormonal milieu is changing. Anatomically, they're changing. They're growing up. And you have to keep that kind of so rigidity, inflexibility on a part of a clinician is not going to serve the purpose. You have to make sure that you keep the forest intact and not focus on the trees as well.
Yes. And when you're dealing with ADHD, which manifests behaviorally, we have to really understand whether this is really ADHD. Is this, family discord? Is this acting out? Is this trauma? There's so many things to consider because that will determine the treatment. If it's behavioral issues related to trauma, you're not going to be treating it like ADHD, even if it looks the same.
Absolutely. And trauma is overrepresented, because of the nature of the thing. And I think that's why psychological management in children or youth often does not get talked about. People only talk about CBT, but there are behavior therapies. There are psychosocial trainings, family therapy, improvement of interpersonal conflict via peer mediation. And I said that to a parent a few months ago. I said, what are you talking about? Well, you need to dive into it. There's a lot of conflict in the playground, for example. Peer mediation is important. Self-management training, social skills training, support groups. So I think it's all the potpourri which one has to look into that in some shape and form. And really, because sometimes, because the age of the child, sometimes 6, 7, 8, there is a philosophy of postponement, not trying to make the cure worse than disease itself. All medications have got side effects. We have to balance short-term, mid-term, and the long-term risk versus benefit ratio. In all three, if the risks outweigh the benefits, we don't take that route. If the benefits outweigh the risks, yes, we do. But again, not short-term only, long-term as well. One has to look back and think into that and try to just lay it. So sometimes people in my position say, 6-year-old has ADHD, let's emphasize more on psychosocial treatment. Let's emphasize more on the school milieu. Let's emphasize more on behavioral interventions. Let's emphasize more on peer mediation and conflict resolution until such time the child turns 11, 12, 13, 14. And yes, then I will come in with medication, because there I can improve the risk versus benefit ratio, because all medications have risks. There's not a single medication created that doesn't have a side effect, is what I'm saying. So I think that ethos has to percolate in our way we approach managing children with ADHD.
And that is so important to look at the risks and the benefits, because like you said, with any medication, there are going to be risks. And you have to look at whether or not, like you said, the benefits outweigh the risks. And that will be different for every child and will be different depending on how they present, will be different based on their history, will be different based on the environment in which they live. There's so many things to consider.
And just not to belabor the point and take too much time. For example, I've prepared a list in my practice for the past couple of decades. For example, the principles of parenting adolescents diagnosed with ADHD. And I'll just quickly go through them. Give more immediate as well as frequent feedback and consequences. Use more powerful consequences. Use incentives before punishment. Punishment has to be a means to an end, not end to the means. Oftentimes, we forget that. Strive for consistency. Act, don't yak. Pardon my language, but I try to be very specific so the parents can get it. Plan ahead for problem situations. Maintain a disability perspective. Don't personalize the adolescent's problem or disorder. Practice forgiveness. That is spiritual. Encourage and shape responsible independence-related behavior so separation versus individuation can come in. A mom and a dad cannot be with a child and be his or her executive function ad nauseum, ad perpetuum. Divide the world of issues into those that can be negotiated and those that cannot be negotiated. I'm going on a Sweet 16 party. Everybody was smoking. Excuse me, that's where I draw the line. Sometimes you want to be friends with your child, but, maintain good communication. Actively monitor the adolescent's behavior outside the home. Maintain structure and supervision longer than it may appear necessary. Be the adolescent's cheerleading squad. Encourage the adolescent to build on his or her own strengths. Use a problem-solving approach to enhance communication skills or conflict resolution. Engage in strategic, structural interventions to restore parental control when necessary, not tactical. And of course, with the social media, with the online addiction, with the YouTube, with the TikTok, you know where I'm going with this last point. Negotiate. You cannot say all or none. These are the rules over here. For example, one of my parents of a 16-year-old said, well, you have the right to go and check what's being done on the account. At random, I'll check 10 of your emails. At random, I'll take your 10 of your TikTok, journeys or YouTube, whatever that is. And if I feel that you have crossed the line, then that privilege is going to be taken away. The world is not full of pack of wolves, but wolves do exist online as well. You know where I'm going with that. So it's just a summary. People think that going to a child psychiatrist, I'm going to the magical potion, which I do. But these are the things like that. Many parents have found that helpful to set that tone as a part of it. So I hope I'm making the point clear in the way I presented it, that it's a very comprehensive, holistic approach versus very narrow, truncated approach.
And that's really key, because I think sometimes when I make a referral for a medication consult with a psychiatrist, they're thinking that they're going in just for a medication treatment option, but it's so much more than that.
Yeah, when I'm on the point, you can edit it. For example, I prepared a list of things that I've been following up for almost 2 decades, which I'm sure, Karen, you do much better than I do. My recommendations for teachers to manage students diagnosed with ADHD: provide clear, brief, and frequent instructions that are visible and based on external modes of presentation. Not rocket science. Provide consequences that are delivered more immediately and changed more often than for non-ADHD children to prevent habituation or satiation. Something which should speak to you. Use consequences that are more powerful, higher magnitude, but that are primarily positive than those normally used with average students. Positive reinforcement versus negative. Focus on providing a richer degree of incentives or motivational parameters that normally used in a classroom setting. Remember that appropriate behavior must be rewarded before punishment can be implemented. And lastly, learn to anticipate problems and to plan ahead, particularly during phases of transition across activities or classes to help you diagnose with ADHD. Recognize when shifts in rules and cannot be rigid. You have to go. This is classical Russell Barkley and Associates, one of the giants in the field, who comes from a non-MD background. I'm not reinventing the wheel. I had the pleasure of meeting with him 3 decades ago, and I've incorporated that in my practice. So when I'm working with a child who is on my medication, these factors are not ignored. And many of the kids in the private school setup, for example, in the milieu where I practice, they find it quite, and they have used it as a part of their strategy for the children and adolescents. That's the sort of a lay of the land, which the way to approach how the mind of a child psychiatrist should be working.
Absolutely. And that psychosocial support is needed both at home and at school. And this is in addition to, again, medication is never the only treatment for ADHD. It has to be a holistic approach, like you're saying.
Both for the teachers and at home.
Yes.
I would go as far as saying they have to come in first and implement it before you walk on the journey. Because one of the things which parents need to understand, ADHD medications are not antibiotics. Take a course for 6 weeks, we are done. For 3 weeks, we are done. You take them day after day, month after month, year after year. Yes, you give pauses, you wean them off, but the journey, once the door is open, that's why you don't take that decision lightly. You have to dive into it. So balance that risk, but like I said, short term, mid term, and long term. Because once you are on medication, then the monitoring comes in, because you will stay on them for a long period of time. This is not that you're going to use it for 6 months. Goodbye. End of story. No, it is on and on and on and on. Decision cannot be taken lightly. Other things have to be implemented. The child is not in the right school with 40 kids. I'm not interested in starting medication. Take care of that first. severe ADHD, severe inattention, 10 kids in a classroom versus 40 sitting in front of the classroom versus the back, take care of that first before coming in with medication intervention.
That's one of the reasons why I love the work that you do, because there are other things to consider before jumping into medication, and you don't jump into it lightly.
And sometimes parents do get disappointed. We have come here for you to write the magical potion, but make haste, make waste. And I always let them, I think of your child as a parent. That's what child psychiatrists are. I mean, the transference, if I could use a little bit technical word, is quite parental. I mean, there's just no other way. That's how we differentiate from our adult colleagues. And under 18, you're not an emancipated adult. So you are part of the larger team to guide, to nudge, to cajole, sometimes to be firm. And that's what parenting is. That's what child psychiatrist is. And sadly, in my case, to nudge, to guide, to cajole, to convince, to educate, it includes parents. Not to say that I'm a parent of a child as well, but you get the point. That parents need that kind of a sort of a holistic approach as well, so that they can get the perspective right as well.
Right. And when you have a parent and you've spoken to them and you realize, you come to the determination that medication is appropriate for this child, in addition to other treatment options, psychosocial support, educational accommodations, changes in the family system or other factors, then what can parents expect in their journey once they start medication? Is it a prescription's written, and then what does the follow-up look like?
Yeah, so I think the point is that some of the medications are time-honored. Everybody has heard about Ritalin, methylphenidate as we call it. But I use the word Ritalin, people are much more common. 60, 70 years. It actually used for the first time in the Second World War in the Battle of Britain. I was quite amazing that the radar operators could pick up the German planes much more quickly being on it, which is an unknown fact in the history. It does work. But I think risk versus benefit ratio. We have methylphenidate if you're asking me to go into detail in medication, I shall do so. Ritalin type of medications, immediate release and slow release. The slow release forms comes in Concerta, Meditate CD, Ritalin long-acting, and many, many other various forms. So the world of psychopharmacology of ADHD can be divided into stimulants and non-stimulants. Stimulants have been the bread and butter for the past 6 decades, if so. And top on the list is Ritalin, but you have to be very hawkish about monitoring unusual side effects. Broad-based insomnia, for example, decreased appetite, for example, abdominal pain, for example, headaches, sometimes mood changes, loss of weight. Long-term height can be an issue. So one has to monitor that as well. Velocity of growth and all that stuff really comes into play in monitoring. The second class of stimulants are the mixed amphetamine salts, dextroamphetamine, Adderall, Vyvanse. Fewer countries in the world use it, the United States being one of them, and along with Canada, and actually now Brazil is also using, and some other countries in the world have gotten on. It's slightly more potent effect sizes, but also has a higher risk-benefit ratio. Nothing wrong with the medications, FDA approved from age 3 to 6, actually 6 to 18, as we say. For some odd reason, mixed amphetamine salts have been approved by FDA from age 3 onwards, which I do not know the reason. I have not given it to such a young child in my practice, so to speak. So the stimulant is various forms of these, either in rapid release or slow release. And that pretty much has not changed for the past decades. Then you come into non-stimulants, which I also have got. So in a very hyperactive, impulsive child, guanfacine, Intonib is a long-acting form, non-generic guanfacine is slow release, and clonidine, slow release or rapid release, also comes into play. Predominantly for hyperactive, impulsive child, less so in enhancing focus. Strattera or atomoxetine is another I'm just giving you a very brief summary of you get a flavor called Strattera. Has been there since 2004. We like it. Their effect size is slightly smaller on the lower side because they are not that potent. And the only new kid on the block is Qelbree, Qelbree. Year and a half, maximum 2 years, came into the collection, and 6 to 18, again, approved age. It's called viloxazine. So we are getting to know experience on that. as well. And I've been quite encouraged initially. Now, there are off-label usages of medications like tricyclic antidepressants from old time, amitriptyline, imipramine, nortriptyline, all that stuff. Bupropion, often used in adults, mostly in older kids, not in younger kids under 18. So that also comes in, but that is really, really very finesse psychopharmacology. I mean, I cannot give you a soliloquy on it right now. It's not appropriate for this forum. But there are lots of collection. Again, you match it over there. You try to stay within the FDA guidelines as well. And I have to say that non-pharmacological supplement approach is also talked about, namely omega-3 fish oil.
Mm-hmm.
Google is full of data and articles on that in mild to moderate dosages. Is not a bad intervention. Avoiding red dye, blue dye, and a yellow dye in the diet. So the Doritos, and I'm sorry, mac and cheese with the yellow dye is not part of it. You have to look into that. I mean, I don't want to get to the point. Saffron has got studies now coming up. The herb saffron is being used a lot now in ADHD, and there are some published studies to support that. And much more important is the Ayurvedic old supplement called Bacopa, Bacopa. By the way, they are not prescribed. Parents have to do their own research, balance the risk-benefit ratio. These are mostly organic stuff, so to speak. There are organic forms available. Bacopa, for example, is the powdered leaf of a plant used for memorization. That has been tried by so you open the door and educate them and let them make their own informed decision as well. They can be used by and large by monitoring the drug interactions with medications, and can be used independently as well. Where you're trying to postpone the strong medications coming in, you try to make sure that you start with some over there. Halloween is on the 31st. Child psychiatrists do not like the 31st, and especially the 1st of November. Can you imagine a kid having a whole bag of sweets? I mean, I'm telling you. So I always tell them to bargain, buy them out from the child, because 1st of November is hellish for us. He's berserk. He's not listening. Your medication is not working. Well, Mom, last night on Trick and Treat, he gobbled up 50 to 100. He's in a sugar rush right now. So can we just get that into perspective? So, and always, like in October, I've started setting up that I want to know what costume you're wearing, but can we promise that we're not going to take this? You don't want to take the joy away from the child. Let him go for Trick and Treat, but he doesn't have to have a bag full of 100 sweets in the evening before he goes to bedtime, because the next few days are going to be not that good. You know what I'm talking about? I mean,
yeah, absolutely.
Halloween is Halloween for us. I mean, here is our Trick and Treat. I mean, I'm just fascinated over this. So I tell parents, I must say, in the west part of town where I live in, 1 cent is not flying anymore. I mean, I will give you 25, a quarter for each sweet I'll buy off you, that kind of stuff. So that they don't, under the bed and chocolates and all this stuff, and you know what I'm talking about. So you have to look at the milieu where the child is. The idea is not to jump and change the medication on the 2nd of November or the 1st of November after what child has gone through on 31st of October. You get the point. I mean, you have to try to preempt disasters, try to minimize, let the child have his joy or her joy, but at the same time, within reason. Can we just shorten that? 20 years ago, I mean, why are you spoiling my day? I can have as much sweet as I like. Well, you cannot, kiddo, because you are taking Concerta under my supervision for your ADHD, and I just do not want any of us to miss the forest for the trees.
Right. And that's why that limit setting is so important, and being aware of other factors that also influence ADHD symptoms. You talked about, red dye, certain foods, sweets in particular, and just to be aware of that, and also to be monitoring that and having that on your radar.
You asked a specific question about psychopharmacological management of ADHD. That was the question. And I have prepared a list of things which I go through. I'll quickly go through that in a little bit of rapid form. Educate the patient and the parent, depending on the child, about the purpose of these medications, clarify the goals of medications, improving concentration, decreasing impulsivity, others. The clinician should avoid focusing only on medication in the clinical encounters. This implies to the families that medication use alone should be a remedy to all problems, which it's not. It further implies that when things are not going well, the problem must be with the choice or dose of medication, which frequently it's not. this shift responsibility for problem completely to the clinician, who must then urgently find the right medication. Tactical movement. Like I said, 1st of November, I get this. It's not working, but it's not going to work with 100 chocolates in your child from 5 to 8. And either, by the way, I am very hawkish. For me, 8 o'clock is the cutoff time after sunset, 9 for old adolescents. I don't want a 6-year-old trick and treating at 12 o'clock at night. I mean, and that has happened, Karen, as you know, in the work which you do. Be sure the patient, the parent understands that medications are not curative. That's a very important point.
Yes, it's not a cure.
It cannot be a cure. Correct any myths about medication the family may have. For example, medication will not correct family problems, alcoholism in a parent, contentious custody battles, etc., etc. These are important points. I'm being very transparent. Wait for the patient family to approve of a trial medication period before embarking on medication management. Do not force medication on a child or adolescent. Because many adolescents, I don't want it. Why are you giving it to me? The problem is with the school. The problem is with my teacher. I don't like my math teacher. You know what I'm saying? You've got to get into the depth of it. Provide a thorough evaluation of the patient and family to determine possible comorbidities, which we talked about. Things, other stuff, tics that may benefit from other medications. Be supportive of other management tools, psychoeducation strategies, behavioral therapy. Begin with a low dose. That's the key point. And increase slowly until identified target symptoms are sufficiently improved. Do not go for the maximum solution. You cure versus disease. I would say stop the medication if side effects are unacceptable or upper medication levels are reached without any improvement in target symptoms. That's where the scale, the Vanderbilt in the corners comes in regularly, once a month. But, everybody's saying the child is doing so much better. I need to know how he or she is doing better. Specific medication doses may vary from patient to patient. And of course, ethnicity, genetics plays a part. That's a very important point. May require a medication dose higher than needed for adults because of increased renal clearance of drugs, lower body fat percentage, increased liver metabolism, or idiosyncratic medication metabolism. Parents sometimes get concerned, why are you going to a higher dose? Because he's flushing it out much more so than some adult of a similar situation. Strive to achieve complete syndrome remission if feasible, rather than settling for a symptom improvement. Response versus remission. 40% improvement is not good enough for me. Once you've opened that door, you should go within reason, balancing all the caveats to the remission of symptoms as well. And share responsibility explicitly by clearly stating that issues that the family must work on, the school must work on, the child or adolescent must work on, and the physician must work on. It's a team approach. Once again, it is very important. I'm working hard. I want you, work, meet us halfway. It's a potpourri. The parents have to work hard, which I said very clearly. And last but not the least, the school has to work hard. And the final point I have to say with humility, ADHD is a genetic disorder. Many times when you do that, now I do not look after the parents. When I see clearly the presence of ADHD symptomatology, how many times do I get a call in the morning? I've given double the dosage. I do not know if I missed the dose on a higher dose. I mean, then I'll have to say, mom or dad, maybe time has come for you to be evaluated. You have to understand you're dealing with a genetic disorder. I don't want to be pejorative, but, it is a linkage, and maybe improvement in your lifestyle may improve the overall family milieu and family systems and family function. I think oftentimes not having the courage to gently, empathically, and with sensitivity approaching it. I've come to your office to get my child treated, not for you to focus on me. Well, the child does not live on an island in Fiji, lives at home. Can we be clear on that? And last month alone, you called me 3 times. I do not remember. Did I give him double the dose? I mean, there was one ER trip because the dosage was high and you by mistake. So we need to look into that. And life is complex. You're multitasking as a mom. I'm just giving an example, a clinical example over there. Deciphering ADHD symptomatology in one or both parents. It's not wrong. And of course, because of, conflict of interest issues, I don't treat parents by and large. I just, hey, you may need to see somebody else who can manage this in some shape and form.
Yes. And that speaks to the idea that this is a team approach. Everybody's coming in ready to support this child. And if it's a child, they're ready to do what they need to do. in order to work hard at school, in order to comply with the medication regimen. And the parents are there to create a home environment that supports the child's struggles, to provide the structure, to set the boundaries. And the school is there to make sure that that child is getting their accommodations and the support needed, the modifications needed for them to be successful.
And the school psychologist, educational therapist, coach, child is a sports maven. I mean, they also become the secondary part of the team. And the pediatrician, don't forget that. It's a pediatrician as well. Monitoring, keeping in close liaison with them in the annual child checkup, the height, the weight, all that stuff. It's a very comprehensive approach. Yeah.
Dr. Naqvi, I can't thank you enough for being here and allowing me to ask you questions that many parents have asked me, have asked my colleagues. So thank you so much. What is the best way for people to reach you if they would like to know more about your work or have questions?
Best way is to, I would say, email is the best. I'm a bit old fashioned. And Karen, you've known me for past couple of decades. I'm very shy, with utter humor. Is the email would be the best way to reach me, and myself or my office will respond to it. My email address is very simple. It's Naqvi Healer. I'll spell it for you. Naqvi Healer, HEALER @gmail.com. Simple. I mean, my email address office is Syed Naqvi MD at syednaqvimd.com. But both the emails go to the same server.
Yes. And I will be sure to put your email address in the show notes. Thank you again so much for being here and for providing such great information.
Wonderful conversation. Thank you so much. Such a pleasure to talk to you. And hopefully this was of some help to many of the parents in your audience.
This episode was filled with a lot of information. It's all great information, but I know it's a lot. I am so grateful to Dr. Naqvi for being on the podcast, for sharing this information. Again, I always want parents to have as much information as they can so that they can make the best decisions about the care for their children. If you would like more information about how to support your child, your teen who has ADHD, I'd love for you to join one of our learning groups that we're going to be opening in January 2023. Shoot me an email at drkiwilson@childnexus.com and I'll put your name on the list. Thank you so much for listening, and I'll see you next time.
Thanks for listening to Diverse Thinking, Different Learning by Child Nexus. For more resources, visit us online at childnexus.com.